This is ophthalmology for the pediatrics board exam. We'll start with strabismus. This is the misalignment of the eyes. You can test for this with the Bruckner test, which is where you check for simultaneous bilateral red reflex and corneal light reflexes. You would refer for strabismus if the strabismus was persistent or if it's intermittent after 6 months of age. You'd also consider referral if the pupil or the red reflex was asymmetric or if it was contributing to torticollis or to eye fatigue. Pseudostrabismus is the false appearance of strabismus, is sometimes caused from epicanthal folds or the nasal bridge. You can use the cover-uncover and the corneal light reflexes to detect if the alignment is actually normal. Strabismus can lead to amblyopia, which is when you lose acuity because of a functional problem. Usually amblyopia is unilateral. It's the most common cause of decreased visual acuity in children, and they're most susceptible for this in the first few months of life. So the next concept is phorias and tropias. So phorias are when the eyes drift apart, but the alignment is maintained by binocular vision. You'd consider referring for a phoria if the patient's older than 4 months old, if they're failing the cover-uncover test, or if the parents are reporting seeing that the eyes are drifting. The cover-uncover test will show that the eye drifts when it's covered and then realigns when it's uncovered. Tropias are when the eyes are apart in a fixed manner but not drifting, so they're deviated in a fixed way. You would refer all patients for fixed tropias. So strabismus, phorias, and tropias can all cause double vision or diplopia, and this would suppress the deviated eye. The brain cortex engages in suppression of that to maintain binocular vision. Glaucoma is associated with which of the following neurocutaneous syndromes? NF1, NF2, tuberous sclerosis, von Hippel-Lindau, or Sturge-Weber? The correct answer is Sturge-Weber. Congenital glaucoma is defined as an increased intraocular pressure. The eyes would enlarge before age 3, and you might see tearing, photophobia, corneal clouding, and a loss of acuity. You would screen Sturge-Weber patients for glaucoma if they have a port wine stain that's distributed over the V1. Cataracts can be familial. They can be from maternal infections, especially rubella. Cataracts are associated with Down syndrome, Turner syndrome, and Hurler syndrome. They're also associated with galactosemia and can be seen in cases of trauma as well. Hordeolums are infections of the eyelid sebaceous glands, to contrast with chalazions, which are just inflammation of the meibomian glands from the fatty secretions. You would treat hordeolums with antimicrobials. With chalazions, you would try to treat conservatively with hot soaking, baby shampoo, erythromycin, and you might consider referring the chalazion if your conservative treatments aren't working for a month, or if they have a secondary infection. The red eye of conjunctivitis can be caused from trauma, allergies, glaucoma, retinoblastoma, Kawasaki disease, uveitis, drug or chemical exposure, trichiasis, which was when the eyelash grows inward, and foreign bodies. Infections can be from viruses or bacteria. The bacteria that we think of are H. flu, strep pneumo, Moraxella, and Staph aureus, similar to the bacteria that cause ear infections and sinus infections. We would treat this with augmentin, especially if it was associated with acute otitis media. We would treat virus, this would be adenovirus, enterovirus, HSV, or paraflu With supportive care, an adenovirus can cause sore throat and eye redness, which would be pharyngoconjunctival fever. We would treat if this progressed to orbital cellulitis with clindamycin and a third-generation cephalosporin. And then finally, neonatal conjunctivitis. This is caused typically by Staph aureus, Staph epidermidis, strep pneumo, and then Moraxella catarrhalis. So similar to the ear infection ones, but more looking like skin flora. We can also see neonatal conjunctivitis caused by HSV. This typically presents in the first 2 weeks of life. Gonorrhea, which typically presents in the first week of life, at day of life 3 to 5, and then chlamydia, which presents towards the end of the second weeks, between day 10 to 14. Retinoblastoma is the most common pediatric ocular malignancy, typically will present before age 5, and it's usually unilateral if the mutation is sporadic. Bilateral cases are usually autosomal dominant hereditary retinoblastoma with an incomplete penetrance in the parents. This is affecting the RB1 gene on chromosome 13. Uveitis is presenting with pain, photophobia, blurry vision, conjunctivitis, and tearing. We can diagnose uveitis with a slit lamp. You'll see white blood cells in the vitreous, and you'll see increased protein count. Traumatic eye injuries include the ruptured globe, which you'll see subconjunctival hemorrhage all the way around the globe. You would apply an eye shield on the bony arch of the forehead to protect this while they're going to the emergency room. The tremulous iris suggests lens dislocation. So if the iris is shaking, you think about Marfan's and homocystinuria, which has upward and downward lens dislocation respectively. The peaked or teardrop pupil, you think about corneal laceration, where the iris is trying to fill in that gap that was caused by the laceration. Decreased cheek sensation, you think about a blowout fracture. If someone describes a cloud moving across their visual field, you think about retinal detachment. With a patient who has raccoon eyes or bilateral periorbital ecchymoses, you think about the basilar skull fracture. With tearing, pain, and photophobia, you consider a corneal abrasion. And then finally, if a patient has an abnormal pupil shape or an abnormal light reaction, you think about the ruptured globe or the third cranial nerve palsy. Finally, we'll talk about hyphemas. This is when you have blood in the anterior chamber between the iris and the cornea. This can manifest with a long-term complication of rebleeding 3 to 5 days after the initial injury when the clot starts contracting. This can cause increased intraocular pressure and glaucoma and corneal blood stain.